Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Catherine Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you have been well trained to care for the tiniest and the sickest babies every day. While NICU parents' scars are not as visible, NICU parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Howdy, y'all. Welcome back to NICU Heroes. I know it's a different voice. My name is Catherine Whitaker, and I'm the new host of NICU Heroes. For many years, it was Kelly, the founder and CEO of Hand to Hold, and she graciously passed the reins over to me. I'm so happy to be here. I'm the mom of 6 children, like we said in the intro, and my 5th baby was our NICU baby. He was our initiation into this new space and this new place. In today's episode, I felt like it was important for us to dive into something that many of you talk about or concerned about. What are some best practices in caring for neonates? And so that is exactly what we're going to talk about. I scoured the internet, and I think I have found, in fact, I know how I found the perfect guest for today. Dr. Anup Katheria is in San Diego, and he has this beautiful background in that 80% of his time is spent doing clinical research, and then 20% of his time is spent doing actual clinical work with neonates. So he has this beautiful background of doing clinical trials, understanding what's going on in research, and really finding out ways that we can help better serve our neonates and their families, and then 20% of his time actually implementing that. And I think that that blend of experience will benefit you today as you learn what are some best practices for neonates. So my guest today is Dr. Anup Katheria. He is a neonatologist affiliated with Sharp Community Medical Group and Sharp Mary Birch Hospital for Women and Newborns. Dr. Katheria also serves as the director of the Neonatal Research Institute and the Nemeth NICU follow-up clinic at Sharp Mary Birch, and he is the principal investigator for several clinical trials. He earned his Bachelor of Science in Biology from the University of California in Los Angeles, his MD from Drexel University College of Medicine. He completed his pediatric residency at the Children's Hospital of Orange County and his neonatal fellowship at the University of California in San Diego. Those are some mighty impressive credentials. He also, on some of his research, is conducting several large multi-center trials focusing on things like cord milking, delayed cord clamping, antibiotic therapy, and many more. In fact, many of those I have no doubt that he and I are getting ready to visit about. I see him nodding right now. So Dr. Katheria believes that all newborns and their families need to not only receive the highest quality care, but they need to be informed about the decision-making process, ensuring that they are still part of their child's care. The empowerment of new parents is one of the best things that we can do for a new mother or father, and I'm grateful that he believes that that is such an important aspect of neonatology. And I am so excited to jump into this conversation with Dr. Katheria. Well, I'm super happy and excited to have the professional, the neonatologist in the room. I'm just the mom who went to NICU school and stayed there a long time, but Dr. Katheria is joining us today, and we're going to talk a little bit about how can we help you as a NICU professional care for preemies better. I know you've been doing lots of research, lots of clinical trials, and we're excited to hear a little bit more about that. But maybe just tell us about your current role as a neonatologist and what it is that you do on a daily basis.
Yeah, sure. And thanks again, Catherine, for
Of
having me.
course.
I'm a big fan of what you've been doing and really engaging a lot of the neonatal community. So thank you for that. So I'm a neonatologist by training, and I, about 10 years ago, started a research program here at Sharp Mary Birch Hospital. So I'm the director for our research program. And my day-to-day is mostly research, although, to do clinical research, you have to be in the throes of the NICU and taking care of babies. So I do both, but I'm about split 80-20. So 80% of my time, it's about consenting moms and fathers and enrolling patients in studies, collecting data, engaging other centers to be able to answer research questions. obviously a lot of writing and papers and grants and that sort of thing too. And so, yeah, I pretty much do a combination of both.
I love that. Well, I think that in order to be better doctors, you have to do the research and then you have to apply what you learn in a clinical
Right.
experience. So I love that you have both, you're both and, not either or, but both and. So maybe let's start from the beginning. So what is the neonatal research, what is the neonatal research network? And then what's the significance of Sharp Mary Birch Hospital, which is the hospital that you're at, and joining that network?
Sure. Yeah. So again, kind of when we started our program, like I said, 10 years ago to do what we call the Neonatal Research Institute, we always aim to sort of establish ourselves as a premier research center. We're always going to be compared against the big sort of university hospitals that have huge track records of conducting trials. And so over the last 10 years, we conducted not only our own studies that were done locally, but we engaged lots of other hospitals both in the US, Canada, and Europe to do larger scale studies to demonstrate to the Neonatal Research Network that we could, in fact, be a site that could participate, engage, and contribute to sort of developing studies and enrolling lots of patients. The whole reason why I came over, I was at a university hospital, did my training there, stayed there as faculty, but I realized in order to conduct large scale studies, you really have to go where most patients get their care. And it's an interesting fact, although universities develop a lot of these great studies, most parents and deliver their babies at large community hospitals. And I think the idea of marrying the two together, where you can have high quality research done at these big centers, you take the top 5 or 10 centers across the country, they're all community hospitals. Some may have an affiliation with the university, but for instance, where you're in Texas, Parkland Hospital is a big community hospital, and that's where majority of Texans will deliver if they're in that region of Dallas. And I think you need to have those centers engaged in conducting trials so parents and families can have access to the latest, most improved care. So what we did is over the past 10 years, after establishing ourselves as being able to conduct these studies, we applied to this network. And it's the first time a community hospital has applied independently without a university sort of attached to it. And we were really thrilled that they accepted us into the network. And so we just joined. So I don't have a lot to share about that in terms of our experience. But since April, we've been engaged as part of one of these 15 centers across the country. And what you do is the network, it was established back in the late 80s to really engage neonatology in terms of standardizing how we do studies. So that way, instead of doing it at a single hospital, you have 15 hospitals doing the same protocol, conducting the same study, and they've been able to have huge breakthroughs in the field of neonatology. They've developed therapies such as, when a baby has a brain injury, to lower their body temperature for 3 days and reduce cerebral palsy. Other studies on looking at how to give phototherapy properly to preterm babies to not harm them, but benefit them in terms of treating jaundice and high bilirubin. So they've done great work over the years and have really been a high quality network. And so if you want to do high output research in the United States, you want to be able to be part of this network to participate and then maybe to even develop other studies. And so, this is going to allow us to join another 3 to 4 ongoing studies. And then we'd like to also develop a few studies that we've been interested at Sharp and contribute to that network. And it's all through the NIH. So it's a federal body. Obviously, every 5 years or 7 years, the government has to be able to put funding into it. But for the most part, our government's been pretty good about funding research and obviously, especially research focusing on pregnant women and babies.
So before we dive into some of the studies that you've done, I'm curious. You mentioned something about this particular study, but we'll take, for example, lowering body temperature. So when that study was going on and we started researching about lowering body temperature and what it can do for our babies, from the time that study was envisioned and you started working on it to the time that it actually was in a NICU where nurses and doctors were actually implementing that, sort of give listeners an idea of how long it takes. I know it may differ from study to study, but about how long does it take from something to sort of be this idea, let's research that, to actually implement it in the NICU? What can people expect?
That's a great question. And actually, so to use that example, we weren't involved. That study now is over 10 years old. And so when I was just finishing up my training, that had become standard practice. But if you go back to what your question was, that's what it took about another 10 to 15 years from designing it to implementing it in small centers to then doing it in larger studies. And then not only was the work replicated in the United States, they did one in Europe as well, and sort of then taking all that together to be able to implement a therapy. But that is actually a great point as to why I've really pushed, even when we've written our grants, like we need to involve large recruiting centers, because one of the challenges of doing these large studies is if the centers don't enroll a lot of babies, then you take longer to achieve an outcome. And then, like your point is, how long does it take? You have this great idea, and you have parents that have enrolled, their baby was maybe one of the first babies cooled, and they still don't have results to be able to transmit for the next family or the next patient. And so what we're hoping, being part of this network, is we're the sixth largest delivery hospital in the state. And so, and the number one in California. The idea is if we can put lots of babies into these studies, we can get them done faster and then get these results out sooner. And I think that's the sort of hope we hope to change the mindset that why should these studies take 10 to 15 years? Why not get big recruiting hospitals? And really, since they're community hospitals, you don't have research infrastructure, but can we put that into them so that they can get these studies out faster and families can get new therapies sooner? We shouldn't move as slow as it has been for many of these studies.
Well, and at the end of the day, you're improving the quality of life of that baby, but you're also reducing the trauma of the parents when you can introduce a study that alleviates some of the hardest parts of being in the NICU. I don't think you can eliminate them all because the NICU
Right.
inherently is a hard place to be, but I think that we can maybe discharge babies faster or technologies that didn't exist. My Preemies 13, things that did not exist 13 years ago are saving babies' lives today. So I'm really grateful for the research that you do. So maybe talk a little bit about how Sharp Mary Birch's research over the years has sort of helped mothers and babies. Like, what are some of the things that y'all have done, practically speaking, in the NICU that have been helping mothers and their babies? And I should say
Yeah.
dads too. I don't want to leave dads out. Mothers, dads, babies,
And
caregivers, all
babies,
those people.
absolutely.
Yes.
It's a whole community. Yeah, one of the things that our center's really been focused on is really the first few minutes of birth. So most of my research has been, my personal research has been focused on resuscitation. So when we look at preterm babies, there's so much that happens in those first seconds, minutes of life that we can really change, or I believe we can really change the trajectory of that child to having long-term problems or maybe even a short-term injury, to really allowing them to transition nicely. As we know, preterm birth is not sort of a natural process, but you want to mimic the natural processes as much as possible. So one of the things we've done, and we're really proud of, is we've been one of the biggest delayed cord clamping centers and done lots of research in showing the benefits of keeping that baby with their mother attached via the umbilical cord for periods of time. I mean, when I say periods, it could be, a minute, 2 minutes, et cetera, to allow that blood to flow from the placenta towards the baby. An interesting fact is that babies born preterm, even under 30 weeks, leave about half of the blood in the placenta. So while they're, in the womb, that blood's going back and forth, but as soon as they're born early, they leave half of it behind. Compared to when you're full term, you only leave about 20% of that blood left over. So it may not be as a big a deal if you're a full term baby, but when you're born early, it's really important to be able to leave that baby connected. And so part of the issues as we continue to do this more is how do we provide support to that baby? Does the baby need extra help or breathing assistance? So about 10 years ago, we started to have these little trolleys or carts where literally the mother's having a cesarean section. We wheel this little table over the mom's belly, and then as the baby's delivered, we put the baby there and we start oxygen or giving them support while they're still connected. And the same thing can be done during vaginal birth. But the idea is don't rush, leave the baby there, let them have some time to transition. And I think it's benefited lots of our babies. Before I came, every preterm baby who's born, and this might have been your own experience as well, is that the obstetrician just cut the cord and handed the baby over to doctors like us because they said that baby needs help and we need to give them help. But part of that help starts even before they get into our hands. And I think this is an area that we're trying to push, not only at Sharp, but like at lots of hospitals that we've developed collaborations with. And it's become more and more standard, but we're trying to focus on the tiny preemies as well, not just the big healthy term babies, but how to get the support for them. So over the past 10 years, I mean, we've had almost 3,000 babies enrolled in these sorts of cord clamping studies, and it's really had a huge impact, I believe, on their families. The other thing, it's not just blood. I like to talk about this. This is blood that's full of stem cells and all these important things that could help these children, not just in the infancy toddler period, but as they grow up to become adults, et cetera. Stem cells, as you know, is a huge field right now, right? People are trying to develop therapies, but they're even giving stem cells back. So I always think, why not just start off with as many of them as you can as a baby, especially a preterm baby who's trying to fight for their life and trying to prevent getting injured. Having these stem cells are probably one of the best things we can do to give them a boost to sort of start up a little bit higher while they're trying to get through the NICU and that early childhood period.
So are you saying, Dr. Katheria, that if a baby born preterm, that you delay the cord clamping? I know you talked about that 50% of blood that they leave behind. Are they able to absorb more of that 50% by leaving them continue to be clamped, or before you clamp that cord?
Right. The idea is that as the baby's delivered and they're starting to breathe and sort of transition, that more blood will be flowing towards them.
That makes sense.
So we call it like a placental transfusion. Instead of a blood transfusion that you'd get from a blood bank, this placenta that's still in the mother is providing that additional blood towards the infant as they're starting to gasp and move around and as they need that extra source of blood, to open up their lungs and that sort of thing. So yeah, the idea is the longer, or at least at some period, waiting to balance what you need for the mother and the baby, but giving them that sort of delay might be able to help them with these other outcomes.
No, that's fascinating. I mean, I'm thinking of my own emergency C-section where as soon as he was born,
Right.
um, straight to the NICU. It
Yeah.
it didn't. So as you're talking about having that cart there to do the things that you need to do to keep that baby stable, but also
Right.
allowing as much goodness to flow through the placenta is like a
Yeah.
magical thing. So to help that baby, give them the very best start in life, absolutely fascinating. So when you say a cart, like maybe walk us through like what exactly is that so that people can sort of have a vision of what you're talking about.
I guess can we do it on visual? Let me just see if I
Yeah,
can
you bet. Yeah,
unblur
so
this.
if you're
So
listening to this, you should watch it on YouTube because you can actually see a visual. We got
I didn't
we
know we
got
were going to
props.
do this. So yeah, it's random that I had it behind me. So this is let's see if I can set it up. But this card, this is one of them. I mean, you can have all kinds of different items, but this would essentially go over the mother. She was laying down here. It'd go over
So for
her.
those of y'all listening, it sort of looks like a food tray, like when you're eating, that the tray
Right.
comes,
Yeah,
except
it's
it's
like
got the sides over. Yep.
yeah. So the baby would be delivered here, and the head of the baby would be here with the cord sort of hanging over the edge of the bed. And then if I provided support, you can see this little oxygen mask, I'd put it on the baby and then just give them some oxygen or breathe through them if I had to, if they weren't breathing well. And the idea would be doing this for could be a minute, could be 2 minutes, could be a little bit longer, depending on this type of situation. And then once the baby's stable, then the OB would cut the cord and then move the baby over to whatever else we needed to do. Like in the case of your baby, just going over the NICU once you were finished. But yeah, this is just one of many. And I don't have any ties to any of these things. So there's people developing their own. There's people just putting the baby on the mom's abdomen, which is fine too. We just like having
Sure.
sort of a flat surface that provides a little bit of heat, which is one of the advantages of a little
Right.
cart like that.
See, people didn't know they were going to get visual aids today. I love it. I'm so glad that you had that behind you.
Yeah,
Um,
yeah. Okay.
so let's dive into some of the clinical trials and some of the research that y'all are doing that you're currently participating in with the research network. So, what are some of the things that I know we talked a little bit about cord clamping, which is fascinating. We could have a whole other episode about that. But what are some of the other things that y'all have directed your attention to that you think are going to help improve that experience for both parents and for babies?
Yeah, no. So there's the only other study, just before I get into a few of the NRN studies that we've just finished right now, was many babies, they need a medicine. And again, I don't know if this was experienced with your child, but they need a medicine called surfactant that allows the lungs to sort of open and close. It's sort of, I explain this to parents like a balloon. When you first inflate a balloon, it takes a lot of force to open the balloon. And then as it's blown up, it gets easier to blow air into it, right? If you've all had that experience. Preterm babies' lungs are like that deflated balloon. It takes a lot of force to open it. And so there's this medicine that we all give babies called surfactant. It's like a little soapy substance. And what it does, it makes it easier for that lung to open and close. So that baby's effort to open their lungs is easier. So getting to the point of the study is that most of those babies, the only way to give it to them is to put them on a ventilator. So we put a breathing tube in the baby, and then we put them on a ventilator, and then we take them off the ventilator when they're stable and able to breathe on their own. But the problem is ventilators, and this kind of came to light during COVID. We don't want to put people on ventilators if we don't have to, because it's probably not a good thing. And so one of the techniques that was actually being used in Europe a lot was they would give the medicine through almost like a little tiny straw, like a little catheter that you just put into the mouth, and you would squirt the medicine into the trachea or the back of the throat. And the babies would be breathing the whole time. And they were reporting these great outcomes in Germany and some of these other countries. And so we thought, let's try to do our own study here in the United States. We recruited a couple centers in California, and we just finished it. So we presented our results a few months ago, in about 180 babies, and showed that not only were we successfully able to do that, but these babies ended up having less lung damage before they went home. So they didn't need oxygen or other support. And few of them ever needed to go on a ventilator. So the other group that didn't get this thin catheter, which is what we normally do, most of them ended up being on ventilators. But these babies that we did this method, it's called less invasive surfactant, or the acronym is LISA. And that's
we have to have an acronym because it's the NICU.
We
you
love
must
acronyms.
have an acronym.
Yeah, you must have the stories of listening at the bedside with all of those. I'm sure is always fun for parents. But that's a study that we were just wrapping up, and now we're following these children out to 2 to make sure they're doing well, seeing whether or not they're having better, lung function, or maybe less admissions to the ER, those sorts of things as well. So that was one that we just were doing at our Sharp Center and a couple others, and we may end up maybe even doing it through the network if that's another thing that happens. But so those are studies that we've been doing here. And then the Neonatal Research Network that we're now joining a part of has a few other studies. One of them is looking at it's called cycled phototherapy. So phototherapy is pretty common in preterm babies. So they get put on this big blue light, right? You probably remember this. And they look at a level in the blood, a bilirubin level for jaundice, and said, oh, your baby's jaundice. And they put the light on. And then the next day they check it again. And if it looks stable, if it's stable, then they'll stop the light. And that's been our practice for years. And it seems to work and lower the levels. Now there's been a sort of argument, well, maybe we should minimize the amount of light the babies have to experience. So the idea of cycling phototherapy. So for every hour the baby's on, you sort of turn the light off and turn it back on. And you still check the bilirubin the next day, but now the baby's getting less exposure to the light. And the idea, it's sort of like what we see in the regular adult world. Too much UV rays, is that bad for the skin? Does it cause DNA damage, or does it affect how your long-term risk for cancer or other things? And babies are worried about, does it have any effect of long-term development? So this study, which is, I think it's over 1,500 babies that they want to enroll, will look at the normal group, which is just leaving the phototherapy on until the next day, or cycling it to see if it improves long-term outcomes in these infants. So that's one study that we're joining. It's probably halfway through already, but we'll be one of the centers contributing to that. Another study that they're doing is one looking at giving a little bit of steroid medicine into the surfactant. So I just gave you that example about surfactant, but if you give this medicine called budesonide, which is an inhaled steroid, oftentimes asthmatics, when they come into the emergency room, they'll get something called Pulmicort to help them with their asthma. And so normally you give it to pediatric patients with a nebulizer. Babies, you might put it down in a breathing tube. And so now they're mixing it in with surfactant to see whether or not it reduces long-term lung damage. And there have been a few single center studies or small studies that have suggested it's beneficial, but we need a major US trial. And they're actually trying to go through the FDA, so it could be an approved product. And so that study is still about halfway through, but we'll be joining that as well. And then the last one that they're doing is, this one's a little bit, I think the best way to explain it is babies, when they're born, they have a blood vessel called a PDA. I think you'd understand this because you've been through the NICU, but for other people that are listening, when babies are inside of their mothers, they don't need to use their lungs. And so the blood gets bypassed from the heart to the rest of the body through this little vessel called a PDA. And in preterm babies, it oftentimes stays open, and sometimes it can cause problems. But as doctors, we don't always know the right approach. Should we treat all these babies? Are the drugs more harmful than not treating, or should we just sort of wait and see how these babies do? So there's another large study looking at conservative treatment versus aggressive treatment. And babies that the clinician may not be sure what the right approach is, and trying to determine whether we should be more aggressive with treating these PDAs or not. And that study also is like halfway underway as well. So these are three major studies. There's a lot of new ones in development that the network might be proposing over the next couple of years. But the idea is that all of these 15 centers are enrolling these same patients and following these exact same protocols, which, the idea is maybe we would get better, better results. And one of the nice things about the network, it's not just about the short-term outcome, but also the long-term outcome. We all have to follow these children out to at least 2, sometimes 7 to 9 years of age. That obviously gets more challenging, as you know, families move around and so forth. But I think it's really important that this network is really held to a high standard of tracking and following patients. We provide support to families for transportation and that sort of thing to really emphasize that we don't just care about your baby going home alive from the NICU. We care about how well your child's doing long term. And I think that's been a really nice thing about this network.
Well, I certainly think as parents are thinking about, and NICU professionals who are listening to this, it's always the NICU reunion is always an opportunity to see how far babies
Right.
have come. So you see a baby leave, but then I think it's great that your research follows them to even 2 years plus
Right.
outside of the NICU. Because when I think of our experience as a NICU parent, while we were in the NICU, and quite frankly, even the first 18 months post NICU, it was like the vortex. We could not escape the hospital. We just like kept coming back. But
Right.
then now he's 13, and I think when you can look at a study long term and be like, was this the thing that allowed this other thing not to happen, can be really beneficial as you start to say, like, how much should we implement this? I want to go back real quick to one of the studies that you were talking about, surfactant and the steroid that you give babies on their lungs. I know many moms go through steroid shots if they're going into preterm
Mhm.
labor to sort
Right.
of speed up the development of the lungs. So, what's I guess the relationship between that steroid shot that moms may get when they're pregnant versus the steroid that babies get post delivery?
Yeah, that's actually a really good question. Because nowadays, almost 95% plus of our pregnant women that come in are getting these steroid shots very, very soon, which has been really a good testament to better obstetrical care. And that steroid, or it's called betamethasone, that's given intramuscularly to pregnant women. The biggest benefit is acceleration of lung maturity. So what that does is it allows those babies' lungs to be able to, sort of like surfactant, to be able to be open and closed more easily, and also have better sort of brain development maturity. It allows the blood vessels in the brains to stabilize, so you get less bleeding in the brain. So those are the two big things that the really old trials that looked at this have been able to show in our babies that are more exposed to antenatal steroids. Now, after birth, steroids have a little bit of a different role because that lung, whatever maturity it's had, it's done. You're once that baby's born, that sort of development of in the lungs, we sort of liken lungs to like a tree. So the tree that has more and more branches can get more and more oxygen from the blood, but a tree that gets pruned back has more difficulty. And so we oftentimes explain this to families that the more preterm your baby is, for every week of life they're born early, now we go down almost 22 weeks, the tree is very pruned. And so steroids can help sort of accelerate some of that maturity, get some of those branches out. But after they're born, it's sort of set. And that's what we're sort of dealing with in a preterm baby. Now, when we put them on ventilators and they're exposed to injury to their lung, that creates inflammation. And so the steroids designed to reduce inflammation in those babies. And so the idea is that for this study, if you give it soon after birth to those babies and you minimize that inflammation right after, maybe that baby can have sort of an easier time sort of transitioning, getting off the ventilator sooner, and having better lung growth afterwards. So they're not, dealing with all this inflammation and scarring, and that sort of develops this, what we call chronic lung disease, where they're
Hmm.
needing oxygen for long periods of time, sometimes even going home on it. And so sometimes we'll give them lots of oral steroid, but this might be a better approach. It goes right into the lung. It's not, going to the entire body and causing other systemic effects that we worry about.
And it happens early sometimes. I
Right.
think as parents are thinking about interventions, and I'm thinking about things that our nurses did with us, the early intervention part at the time, you think, oh, this might be helpful. But then
Right.
years, months later, you realize, oh, those things that we did, allowed us to bypass, 300 hours of therapy or whatever it was because you were able to intervene early. So I really love that. I know you were talking about PDA. Our son had a PDA and a VSD, so we had lots
Okay.
of fun things in the
Yeah.
heart. But
Heart.
the PDA, so is it like a rubric, Dr. Katheria, where you say, okay, so if a baby has these certain things, then we allow nature to take its course and the PDA is going to close on its own?
Right.
Or if we see these certain things, then we're going to intervene. And if we intervene, it's going to look like A, B, and C. So tell us a little bit about what that might look like for a baby who has a PDA and a doctor who's thinking, do we intervene or do we not?
Right. No, and the management of the PA has come a long way too, where it used to just be, oh, the ultrasound sonographer sees that PDA, oh, let's treat it. Now it's gotten to the point where we integrate, how sick is the baby? Is the child on a ventilator needing a lot of oxygen? Are they not on a ventilator and just breathing on their own? And you look at the clinical picture, that gives you a certain sort of score or idea. And then you look at the actual heart images. How much is the heart being affected by the PDA, and what is the flow? So the PDA. One of the things we liken it to it's like a garden hose. It's a little. You're looking at flow going through it, and when you kink a garden hose, the speed gets really high. So when you see some of these PDAs, they might have really high what we call velocities or speed, where they're actually narrowing and constricting. So there are some PDAs that, even though you see it there, it might close on its own, even in a sick baby. Or you might see a PDA that looks big, but it's really not bothering the child. Baby's like not on any oxygen or maybe on minimal support. So the idea is to kind of combine those and really, I mean, it's almost like that term that gets thrown around, like precision medicine. For that particular child, how do we treat X, right? And I think we're trying to do that, and maybe the PDA is the closest we'll get to, where we're not going to just do that for everybody. But in the study, what's nice is they said, like, if the baby's really sick and you need to treat the PDA, just treat the PDA. Don't worry about the study. If the baby's like in between, where the clinical picture looks okay, or maybe they're on a little bit of support, and you see some things on the echo, those are the babies that we're not sure of. We'll put those in the study. But they've kind of split the two groups, where if it's clearly not treat or treat, you just do what you need to do. And then the in between ones are they're trying to hone it in and get to that point of whether there is a good approach or not. But yeah, to answer your question, I think we're trying to fine tune it a little bit more than what we used to do.
Well, medicine's a little bit more art than it is science sometimes,
Yeah,
and
I'll agree.
sometimes a baby clinically does not at all match what you see on the
Right.
paperwork and the studies, and then vice versa. So I had a kid who was always like in the 1%. They're like, "Huh, that's interesting." And I was like, "Yes, that's his middle name. That's how that works."
Right.
Um, so Sharp Mary Birch Community Hospital. I know that you mentioned that earlier. Um, what are some of the, I guess, the significance in y'all participating in the clinical trials versus other hospitals, like ones that are affiliated with the university? I know we talked a little bit about that at the beginning, but I guess maybe give us a sense of what that significance may be of the community hospital aspect versus a university hospital aspect.
Yeah, I alluded to it earlier, but again, it gets to the point of what I'm really hoping that we can change how research is being done. And it gets to your comment you made earlier, that if more and more community hospitals start developing research infrastructure, and that's not easy to do. So, we don't have medical students or residents or fellows that rotate at my hospital. It's 12 of us private doctors rounding on patients and talking to families, and we go through our day. How do you integrate where you're doing large studies and consenting and collecting data? Well, you need to hire a lot of people to do that. You don't just have that big university infrastructure where there's people all around helping you do all kinds of things, or students that need papers and things like that will do things for free or help you out. So we have about 18 employees, coordinators, research assistants, pharmacists, even that do research, that work for us and help us conduct these studies. And so the hope I have is that by us joining this network, it can kind of open the door for other community hospitals to say, look, I can do this too. I had never heard of Sharp Mary Birch until I went on your podcast, right? I think people want to be able to say, like, could this be something that we could do at our place as well? And remember, like, of all the NICUs across the country, only 10% of them are universities. The majority of us are all community hospitals. So, and in many states, the only NICUs in the entire state are large community hospitals. There's not even a university there. So if you're talking about certain regions, like in the Midwest, you could be a center to really impact your entire state if you get involved in studies. So that's sort of where I'm hoping this goes, that now we've done it. We're more than willing to help other people that want to do this as well. And the reason I'm doing, I mean, part of it's, yeah, you could say it's altruistic, but part of it's also selfish. I want more centers to enroll more babies so we can get studies done faster. So if they join a network that we're part of, then we'll all benefit. We'll all get results quicker and we can get them back to our families faster. If we keep focusing on university hospitals, and there's no disrespect to them, they clearly have the brain infrastructure, they have the great coordination of care, but they just don't have the volume and they need help. They need partners like us to be able to do that. And so I don't know, that's sort of, I think the next 10 years for us at this research institute is sort of how do we engage more community programs to be able to do that. And hopefully that will accelerate how neonatology works. One of the fun facts about our field, and the reason it's so exciting to do research particularly, we're the only field in medicine that went from a 90% mortality rate to a 90% survival rate. Even oncology can't claim that with all the research we do for cancer. And, I think it's great work that people are doing. They're not reversing care. I mean, how preterm was your son?
So he was 36 weeks, but he was intrauterine growth restricted, so IUGR. So he was about 3 pounds at birth.
Right. So do you know that, John F. Kennedy's son, right, was 34 weeks and died, right, from a pneumothorax or an air leak. And so now that every week we've gone back, every 10 years, we moved like the gestational viability back a week, right? So now I said we're at 22 weeks, and that would have been unheard of. And your son probably 30, 40 years ago may have had a 50-50 shot of surviving. I mean, that probably wasn't necessarily on your radar, but the fact that we're able to do things to improve care for these infants has been incredible. And so it allows really an opportunity for us. We, like I said, after, John F. Kennedy's son died, he put in all this infrastructure to develop research to help babies. And so all these pediatricians there was no such thing as neonatology in the 60s. They said, okay, we'll start doing research. And then people just only focused on babies. And then our field was sort of born out of that whole thing. And so we're all trying to develop more and more of these therapies to help these babies, but a lot of it's, still untested. We're still trying, most of the medicines we use in the NICU don't have FDA approval. They've been extrapolated from adults, and then we try to dose them at tiny amounts. There's so much work we have to do. And I think, getting back to your question, that's why we need lots of babies to be able to participate. And one thing I tell parents, because, when I talk about what I do to people that have no understanding of neonatology, they're like, wow, you do research on little babies? Isn't that not appropriate or unethical? Because these are little fragile babies. And I tell them, babies who get enrolled in these studies, if you look at babies who aren't involved, they actually do better in our trials because we try to offer them therapies that could be better. And if they're not, even in the control group, they're in a standard protocol that we're really trying to watch every single thing in these infants. We're actually paying more attention to them when they're in these trials than when they're not, because they can get anything they want when they're outside of these studies. And so people have shown time and time again, being enrolled in trials have better outcomes in the short term and long term. And, we have a pretty good relationship with our OBs and a lot of the staff here where, we sit down and talk to families and engage them, and I'm sure you can remember this, and, maybe as traumatic as it was, when you're about to deliver a baby or, preterm, or there's an urgent section, there's so much going on in your head and it's very stressful. But if there's ways we can engage families in a way that's appropriate, we've developed, parent advisory boards, or we have ex-NICU parents like yourself. Maybe we'll invite you to join us one day to help us say, like, what's the right way to approach a woman that's about to have an emergency C-section? That seems kind of hard to do. Is there a way where we can sort of talk to them even afterwards, or talk to the father and be able to explain some of these things that we're doing? Or is there ways to do studies where everybody gets the benefit of this therapy, when we can talk to the families about why we think this is important? Can they be involved in the study? And so there's all these nuances about what we do. In some ways, we're like emergency room doctors. In other ways, we're like OBs talking to families over a long period of time, and we're trying to marry these things as we're developing these therapies. So It's a fun field to be in, and I think why most of us go into neonatology is because we love the relationship we get with families over this period. I mean, babies are with us
Right.
sometimes weeks to even months, and it's a little bit different than when you're dealing, with general peds or adults where you don't get that much interaction with people over a long stretch of time. And as you mentioned, those picnics
Yeah,
and reunions
that's
are
certainly been
huge.
like the continuity, or at least the question when I ask it is people why they find themselves in neonatology is this continuity of care, getting to know patients over a long period of time. I'd even say that my son probably had a 1% chance he had a surgical case of necrotizing enterocolitis. So we spent a lot of time.
Uh,
And I think too, where in that particular instance, the research that's happened in the last 13 years, we absolutely would have done things differently 13 years ago.
right,
But long term, we're figuring it out. But I do think that I'm a believer that research, and like you said, in those community hospitals, there are thousands of babies outside of the university system who are who could be great beneficiaries of this research that you do. And so if you have this great pool of willing parents and
right,
babies who are in a situation where you can improve their care, that's a good thing, because ultimately it may benefit someone else's baby who you haven't met yet. But you know that, hey, because my baby went through this and we enrolled in this trial or this clinical study and they found out these things, thousands, I mean, I think of the Kennedys in particular, hundreds of thousands of babies' lives have been saved
right,
because of what they learned there. So, my hope is that that family sees the sacrifice, but that the fruits that came from that, and I would
absolutely.
hope that that would be the case with many parents who maybe are on the fence, or even hospitals who are like, I don't know if we should participate in this, and what's the cost versus the benefit. Um, so, as a NICU professional that's listening to this, Dr. Katheria, what in your opinion, as a neonatologist who spends a lot of time researching, but also a fair amount of time with babies, best practices for caring for a premature baby in the NICU? What are some things that you would recommend to NICU professionals to say these are some things that you should absolutely do to take care of these babies, as well as taking care of the people who are caring for them?
Yeah, I mean, yeah, you could definitely get into specifics, but what I've learned just even in the last 10, 15 years is in caring for babies, probably, the mantra of less is more, right? When I talked about even the waiting to sort of cut the cord and slowing things down and how we care for babies, we're even finding maybe giving less of these medications that we thought might have been beneficial. If we can minimize how often we have to do these things, babies probably can do better. The same thing is true with putting babies on ventilators, avoiding putting them on breathing machines that we think maybe back in the a long time ago, we thought, hey, we should try to manage these babies on these breathing machines. That in of itself is harmful. So we're trying to go to an era now of really minimalistic care, not providing a lot of I shouldn't say care, minimalistic therapies where we're only choosing and picking certain therapies that we have to give because this is it. We restrict how much steroids we give to babies after birth, only a limited amount if needed, limiting their time if they go on the breathing machines at all, if I said that earlier. Um, Trying to get parents to really be involved with, kangaroo care has been a hot area. It used to be this thing for full-term babies, like, oh, mamas would walk around with their babies, these little, I'm totally blanking on it, the
The
Bjorns,
wraps, the pouches,
right? The
yeah,
wraps,
yeah.
right? But what about doing that in a little 25, 24 weeker? Can you keep those babies on the mom or dad's even chest to allow the benefits of, physiological stabilization? Babies have better heart rates, they maintain temperature, they get exposed to the mom's sense and things that might stabilize them more. So I think a lot of it's moving towards, less of the technology and more of the sort of natural approach. And the more we do of these things, I think in probably in the next, I mean, I'm already seeing papers and things like that, but you're going to see NICUs in the future that babies aren't connected to anything. They're just sitting on the mom or dad, and that's the NICU. Maybe they're being monitored wirelessly to something else so people can monitor how they're doing. But I think we're going to see more of that approach. And we're already seeing in other countries that, and this is a whole topic, I don't want to take up too much time, where the families have so much extended leave, right? They just
Mhm.
passed this law in Britain. If your baby's in the NICU now, you automatically get an extra 3 months of leave. So they
That's
can
awesome.
be in the NICU, be with their baby the whole time. And now they're having them provide all the cares. The nurses teach them how to do the tube feeds, teach them how to, maintain the baby while they're in the isolate. And those things have been shown to have been demonstrated to shorten length of stay, improve growth. And I think these are things that we're probably going to see more and more. So if you're listening to this and you're like, well, what are the things I should start implementing? Try to do those sort of minimalistic things where, babies can be avoided being put on these therapies and machines and um, extra medications. Get the babies on the parents as soon as you can to be able to have kangaroo care. And I think you'll start seeing benefits in these infants sooner than later.
I do remember that in the NICU, it took one person to hold the baby, and then it took
Right.
another person to manage all the cords, and then
Right.
it took another person to like get you into a place where you could sit down. So it was like a three-person job for
Yeah.
this one tiny little baby who at the time was 4 pounds. The wires I think weighed more, than he did.
Right.
But
Right.
I do think that but it also sort of begs the question of we noticed this transition. We ended up being in one NICU and then we were transported to another one. So
Okay.
one sort of had the traditional um, care and that the neonatologist would come and around. But then when we were moved to the new NICU, it was more family centered. So really a
Okay.
pioneer in like the family centered care situation. So I'm curious to know or what your thoughts may be when it comes to trials or clinical things that you look at. What's the difference between a traditional model of a NICU versus a family centered care model of a NICU and how that
Right.
sort of affects babies long term?
Yeah. I mean, there have been a few studies looking at, well, I'm trying to think the best way to sort of integrate, but the idea of family-centered care is really involving where the units, the families, not just the patient and then the baby and or the nurse. It's having the parents being involved at some level in sort of the medical decision making or how the babies are doing, being able to provide some input on rounds. Um, and then really the clinician and the team sort of giving then feedback to the parent on what they can do. Because I think one of the challenges, right, is that, and again, you probably experience this, is that you sort of have this period where you almost feel helpless. There's not a lot you're doing. Everybody else is doing things. And how do I get involved? And so I think that really should be where family-centered care starts, which is, and I think that's where skin to skin early on has such huge benefits. I think it's almost probably equally as beneficial for the baby as it is for the parent, to be able to do that. And really, as you know, there's lots of morbidities for parents of former NICU grads, right? It's not just higher rates of depression. Moms and dads that come back to the NICU almost experiences PTSD feeling, the alarms and the noise and things. So how do we help cope with that? And I think family-centered care really does both. It helps that for the parents as well as for the infant's care to be able to have that grouping. And it doesn't really matter in terms of the design of the NICU. It's about the culture and how you involve those families and rounds. But there is this other aspect of design of NICUs where, do you move to these bigger single patient rooms where the parents can room in? And that has benefits to the child as far as language development. Hearing the mother's voice is still better than a recording. People have tried to look at those things. But on the flip side, if the parents aren't there and you have a single patient room, those babies unfortunately do worse because they don't get a lot of human audio input that they would as if they were in an open bay where they hear the nurses chattering and hearing conversations. So there's a lot of those nuances in terms of how do we design our units moving forward, but then how do we do that in mind of the types of families we have? And I'm not sure how it is in Texas, but even in California, we have some families that are able to do, they get the time off, they get what they need to be able to
Mhm.
stay at the NICU all the time. But then we have other families that, the mother and the father have to go right back to work. And so then they're not around at all. And that makes it really challenging too. So you can update them on the phone, but that's not family-centered care. We need to figure out ways of providing those resources at probably the state, federal level to allow for more time. And I think that's a bigger discussion, but an important one if we want to improve outcomes for our babies. It probably does start at the level of giving parents that leave to be able to do that.
Yeah, and just the ability to ask the questions that they need to ask or feel. I know when we first came into the NICU, I was very hesitant to ask any questions because this was a new place for us.
Right.
I was the mom who used to get queasy when they would do a blood draw, and by the end of the stay, I was like showing nursing students how to start a catheter. So I was like,
Oh,
clearly
wow.
we've come a long
Yeah.
way.
Yeah.
But I think this empowerment that I think when we talk about, particularly nurses with a patient, of encouraging parents to ask questions, even if they feel like they might be stupid, or involving them in the care, I think were critical in helping us learn how to be better caregivers for the time that we were there. I know, like you said, some families are able to be there a lot and some not at all, and then some are sort of in between. And so, how do you ensure that their babies, if that's three different families, one who's there all the time, one who's not there at all, and one who's sort of in between, how do you ensure that those three babies get out the door with the best possible care and also the best possible start, even though the circumstances may be different? So, Dr. Katheria, if you had to if you're thinking about research, I know we talked a little bit about some of the things that y'all are getting ready to embark on in clinical trials, like dream thing that you would love to tackle when it comes to improving care in the NICU for both caregivers and babies. Like, what's the one thing that you're like, man, if I could do research on this thing, I feel like it might be incredibly groundbreaking, or I really like this really intrigues me. What would that be?
Yeah, that's a great question. The thing I would probably want to do is sort of marry my interest in delivery room resuscitation, because I mentioned how important I think it is, and then those babies after birth. But I would love the ability to really hone in on starting this like idea of skin to skin and providing therapies even soon after birth. So there are some units that are able to do this, like delivery room cuddles, where the baby gets to, even a preterm baby gets to be held by the mother for even a few minutes right after birth, and sort of maintaining that. I would love to see us sort of translate some of the benefits we've seen, early kangaroo, early skin to skin, in the tiniest kids, sort of from birth moving forward. It would take a lot of logistical challenges, but I think, and probably trying to create hospitals that can provide support where parents can be there all the time and room in, like we talked about earlier. But I do think that's probably one of the most impactful therapies that, we just haven't been able to implement in our country yet. So I think that would be a huge one. But it would involve a lot of things, such as like, keeping that cord intact where the moms can get longer delays, and babies can be held and stabilized while they're still connected. Um, Being able to provide that extra, temperature warmth, if the babies can be with the mothers and not need sort of all this external equipment. I do think there's a way that we could do that if we could have, again, like you said, all the funding in the world to be able to create this sort of infrastructure. But I would love to see that. And I really do believe that could have some of the greatest impact on what we're seeing with our preterm babies.
So, what do you see with babies who receive consistent early kangaroo care? What are some of the things that you notice in those babies versus babies that don't get that?
Well, I'll say we're not where I'd like to be, but we're doing the best we can, which is, we try to give, like, for our small babies, we try to have them have a kangaroo care appointment in the first 3 days. So when these babies that are born, usually around like 28 weeks or under. So these are babies that right at the end of that third trimester. They're small, they're on ventilators, many of them are sick. They can get like an hour or so, where the staff, like you mentioned, coordinating the wires and the ventilator, they'll all do that, and they'll put the baby on the mother or the father's chest for that period of time while they're watching them and stabilizing them. What I'd like to see, and those babies seem to, be able to have better, stability during that period. But I'm not seeing that sort of. I think what your question is, what are we seeing if we're doing it a lot more? And I'll tell you, the countries that have done it's surprising. You think it would be, this big developed country, but Colombia in South America routinely puts every baby, and they don't have really small babies like we do, but even down to 28 or 30 weeks from birth on, and they're reporting. These are some really interesting facts, but not only these babies are going home sooner and having, better development, their MRIs are better, their brain development actually structurally looks better. But they found even such benefits in parents. For instance, if the father is doing more skin to skin, there actually are lower divorce rates in those couples. And this is an unfortunate fact. We actually see a lot of marital stress in parents of NICU babies as well. And the less the father is involved, it creates more stress and havoc. But they've even found that they follow these children. So there's the parental benefit, but the children's, when they're getting out to getting jobs and careers, they actually are making more money. They're having more successful lives because of this early skin to skin. In Bogota, in Colombia, they have data out to 20, 25 years now of doing this early skin to skin program. And that's why when I hear that, I'm like, I think of our babies and just what they're dealing with as they grow up into adults, and and throughout childhood, is this something that could have a dramatic effect if we could implement it? But it would take a lot to create hospitals and infrastructure and family leave to do that. But I think it would be really cool.
Well, it certainly underscores the vast importance of the human touch with someone else. You know, you
It
see that
does, yeah.
in many ways, like when I was just speaking to a family the other day who lost their baby in the NICU as a result of the wife's preeclampsia diagnosis. But they
Um,
were talking so much about how the nurses like laid hands on them, you
right.
know, helped them hold their baby, and how that helped them heal.
Yeah.
So I think that we see that both in death, but also in life, that how it's the human touch that allows people
Right.
to, I think, confront the reality of where they are, but that to know that they're not alone, and that I know you've probably seen tons of studies. I've seen them how babies just sort of their stats are crazy good when they are on the chest of their mom or
Right.
their dad or someone that
Yeah.
loves them versus being, I mean, and I can appreciate that. Laying in an isolette feels awful, but
Yeah.
being, you know, next to someone that I love is amazing. So I can
Yeah.
absolutely see how that starts at really it's how we're hardwired as human beings. So
Right.
that's absolutely fascinating. So you were mentioning about so Britain has done these studies on extended leave and parents allowing them to do that, and then this in Colombia. Like, tell me a little. I'm fascinated to know about this leave situation in Britain and how that is helping families.
Well, I think I just saw it on the news like last week. So I don't know the big impact hasn't, but if you could only imagine if you gave every NICU mother or father
Huge.
3 months to be able to spend with their child, because it's not just obviously, again, you could go back to your own experience, but it's not just in the NICU, but bringing your baby home, and that takes transition time too, and just being able to get yourself situated because you've now gone through a hugely stressful situation, and your child to be able to care for your baby. I think that's I mean, it plays into so much of what, when I talk to parents about long-term outcomes, I tell them that, look, it's not just what our job is to get your baby home safely and do what we can to optimize your baby in the NICU. But the truth is, your child's ultimate outcome is not going to be what's in the next 2 to 3 months. It's going to be what's going to be in the next 17, 18 years. And that's all you. That's you reading to your child. That's you providing extra care for your infant. What you looking for cues and signs of things that they may need, and so we need to be able to support parents after the NICU, which is probably even more important. As much as we want to pat ourselves on the back as neonatologists, we're only doing a minimal amount of work compared to what it really is going to take to make babies have better outcomes. So, yeah, we need to find ways to support that. And I think giving leave early on is probably one of the best things we can do for these families. So, we're never going to be, well, I shouldn't say that, but I think if you're like in Copenhagen or certain countries where they get a year, of leave automatically for families, but even just a few more months where it could be covered for parents would be great. But so the Britain experiment will be interesting to see what they're doing in terms of
Sure.
how that impacts care. I haven't talked, unfortunately, like I said, I just saw this, but it'd be interesting talking to some of the neonatologists or physicians in the UK to see how that's impacting the care. Or maybe they'll start developing some more of these other measures because they know the parents will now all be there all the time. I think that would be really interesting.
No, I'm grateful that you talked about the role of neonatologists and nurses in the NICU and how you sort of help us lay the foundation as caregivers and parents of our babies, and then hopefully give us the tools that we need as family members to feel confident enough to walk out of those NICU doors, and heal the things that need to be healed. You know, reconcile the things that we need to reconcile with, and then help our babies be the best version of who they can be in whatever way that may look like. You know, every baby and every NICU story is different. They don't all end the same. But I do think that these clinical trials and studies that you're doing are helping our babies walk out the doors with the best possible situation that they can endure. And then we sort of y'all pass the baton to us. But I
Yeah.
think that there's a real beauty there in helping us help our babies go out the door with the very best start. So Dr. Katheria, thank you for all your hard work that you do on behalf of babies. I can only speak on mine. I've had two NICU babies, one who spent a ridiculous amount of time in the NICU and one who blew out of there in a couple of days. But I'm
Yeah.
really grateful for the research because I know that it saves lives. And I hope that the NICU professionals listening to this have taken away some really great practical things that they can do in the NICU, but also to be on the lookout for new and emerging technologies that are happening, not just in university hospitals, but in community hospitals around the country. I'm really grateful for that.
Thank you. No, it's really been a pleasure chatting with you and just exploring all these issues. So I really appreciate being
I
on.
appreciate it. Well,
Yeah.
we will do this again sometime, but I'm grateful for everyone listening, and we'll see y'all next month for our next NICU Heroes podcast. But until then, thanks so much, Dr. Katheria.
Thank you. Appreciate it.
Thanks, y'all, for listening to NICU Heroes. If you enjoyed today's episode, please don't be shy, y'all. You can share it, you can subscribe, and you can most certainly review it. We would love your reviews. It's how we reach more NICU professionals. I'll see y'all next time.